Okay, good afternoon all, we'll take this opportunity to thank you for attending this session, which is much awaited by so many of us. It's about hot topic, which is the current talk of the community, whether it's a medical community or public community, about how much immunity we will have after getting infected with COVID. So many questions about the vaccinations. Which vaccine to go with, how much immunity we will develop after the vaccine, some vaccines with 1 dose, some vaccine with 2 doses, and how long the immunity will last. So a lot of questions about the immunity of the vaccinations. I'm sure you will ask us and ask Dr. Antony about if we need to test our antibodies based on the result, we should go for another vaccine or not, how much should we wait for the vaccination. So many questions will be discussed by Dr. Antony, who's the expert in this regard, inshallah. And I'd like to take this opportunity also to thank our management, who actually took good care of us in these difficult situations, and they proved that they care about us sometimes more than what we care about ourselves. So thanks to Prime Health Management in pushing everyone to get vaccinated until we reach the level of vaccinating 100% of our eligible staff, alhamdulillah, which is the only way for us, either here at the level of the hospital or in the community, to go out of this second wave, inshallah, and the initial news that we are going out of it, inshallah. So we wish you all best of health, and we would like to start with Dr. Antony and his presentation, inshallah. Thank you.
Good afternoon, everyone. And it's good to be with Dr. Dirar, who has handled over 100 critical cases in our hospital. Thank you, Dr. Dirar, for joining us with me. Now, it is almost 1 year. I think that it was in last year, almost the same day, the lockdown was announced in Dubai. So initially, our concern was related to the COVID as such, whether the pathogenesis, the infectivity process, then our safety, the drug efficacy. These were our concern initially. Currently, it has changed, thank God. Now we are bothered about the vaccine efficacy. So in order to understand the vaccine efficacy, we need to understand how the COVID plays with our immunity or with our immune system. And then we can discuss about the vaccine efficacy. As such, we all know that COVID-19 is a single-stranded RNA virus with the genome, and then it is supported by the 4 important structural proteins. Of these structural protein, the spike protein is the most important, which is an important, the receptor binding domain of the spike protein attaches to the host cell. Then there is N protein, that is the nucleocapsid, which is important in viral multiplication. Then M and E, membrane and envelope protein, which are important in the assembly of virus host cells. Now within the cell, within our tissue, these structural proteins have been recognized by antigen presenting cells as antigens, and the body reacts to it, both T cell as well as B cell. The B cell produces antibody. And that's how the immunity cascade is initiated. So now we have the various modality to detect or diagnose the COVID. The RNA PCR basically recognizes the genetic component, and also this is important in recognizing the various genetic variants. Now the rapid antigen testing is the other option, wherein which it will be recognizing these various structural proteins of the virus. And then comes the antibody testing for the antibody specifically directed against these antigens. Now coming to our immune system, there are, as we have studied, there is no change at all. As we have studied, there is innate immunity, which we are born with, or the primary response system, that is the innate immunity, and then the adaptive immunity. So coming to innate immunity, this is the preliminary immune response, and that includes three components mainly: anatomic barriers, physiological barriers, and the inflammatory barriers. The skin, mucous membrane, they form the, and the normal flora, this form the basic anatomic barriers. And in relation with COVID, it is the nasal cavity, pharynx, larynx, and the upper GI tract. They form the preliminary anatomic barriers. Then comes the physiological barriers: temperature, pH, cough, sneeze, flushing out of urine. This is for the general I'm just talking about. So these all comes under physiological barriers, except for burp and any other gas expelled. Rest all are important as a physiological barrier. Then the inflammatory barrier, the phagocytes, neutrophils and macrophages forms the primary cells of the inflammatory barriers. In addition to that, the other leukocytes, then dendritic cells and NK cells, they all releases the various kind of mediators of inflammation, and these are important in the initial aspect of in the innate immunity. Then the other is the adaptive immunity. We will discuss about adaptive immunity at the next stage after going through the role of innate immunity in COVID infection. This is the the electron microscopic depiction of COVID virus over the respiratory mucosa. The spike proteins, the receptor binding domain of the spike proteins binds to the ACE receptors over the cell, over the upper respiratory epithelium. And as we can see, the ACE receptors are more predominantly present in the respiratory mucosa, lungs, endothelium, cardiac cells, as well as intestinal cells. This is one of the reasons why the COVID has got propensity for involving these organs. So once this binding happens, the next stage is that after binding, the genetic material is released into the cell, and the viral mRNA translates to produce the various viral components and the structural proteins, the genetic and the structural proteins, and finally they have been assembled together and form a vesicle, and finally result in the release or proliferation of the viruses within us. This provokes a cascade of inflammatory reaction. Now, again, coming to the over the respiratory epithelium, you can see that the COVID-19 virus, how they get, they binds to the cell, as well as then they proliferates, and once they release, this provokes the recruitment of numerous immune cells, especially the neutrophils and macrophages. The neutrophils and macrophages release various inflammatory agents, that cytokines, interleukin-6, and so on. And with this, we will be able to control, this induces cell death, and with this we will be able to, at this stage, if we are able to control this infection, then they will have mild infection, or they may even turn asymptomatic. If this fails, there will be further death as well as further release of the cytokines, resulting in a cytokine storm, which is mainly provoked by tumor necrosis factor, interferons, various interleukins, growth factors, and in addition to that, acute phase proteins like C-reactive protein, then release of ferritin, procalcitonin, and the activation of the complement cascade. This results in cytokine storm. And another important factor here is we measure interleukin-6, C-reactive protein, ferritin, and procalcitonin as the marker of inflammation. And depending upon the interleukin-6 levels, the antagonist for interleukin-6 is given. So this is in the inflammatory cascade which has been provoked. Another important cell in the innate immunity is the natural killer cell. It is again another lymphocyte, Normally, it has a harmonious relationship with all healthy cells by its MHC gene complex. Something like a lock and key, they form a healthy or harmonious relationship. But with virus infection or a tumor cell, this MHC complex will be less, or there can be altered proteins over the cells, and these are recognized by NK cell, and that result in again the cytokine release and cell death of the infected cell. Now, why this is important is this component, NK cells, play a minimal role in the vaccine immunity. Coming to the clinical features of the COVID-19, almost all the features which we discuss about generally, they are related to the innate immunity. This is the old, the Celsus has defined the four common characters of inflammation: calor, rubor, tumor, dolor, and Virchow later defined the functional loss. This is what happens. Calor is the fever, the interferons generated increases fever as a protective response against virus. And then this also causes the involvement of the various systems within the body and is key responsible for the malaise in our body. The next is the rubor or the redness. This is again the chemical mediators which provokes vasodilatation, stasis, congestion, then followed by the procoagulants, and finally, ultimately resulting in disseminated intravascular coagulation. The third is the tumor. It refers to the edema. With inflammation, there will be inflammatory infiltrate as well as edematous fluid accumulation. This is what we recognized in an X-ray as ground glass appearance, pneumonic patches, and then at later onset, extensive pneumonia. So that is the tumor. Then comes the dolor. Dolor is about pain or the various mediators that induces pain. This is how we feel like as if we are breathing through a chimney and so on. Then comes this is also another reason for the anosmia as well as loss of taste, because the nerve endings are affected with the inflammatory infiltrate and the chemical mediators causing this. In addition to that, for this anosmia and loss of taste, there can be a CNS involvement also, can be another reason for the development of anosmia and loss of taste. The most important is the functional loss. The cell death of the alveoli causes hypoxia, and depending upon the extent of cell death, the hypoxia, the intensity of the hypoxia used to be. That is why some patients we may have to discharge even after they become COVID negative, and then we may have to discharge with oxygen mask or so, because of the loss of the alveolar cells, and regeneration of the alveolar cells take a longer time. So the role of innate immunity with COVID has been discussed. We'll just go through the secondary response, that is the adaptive immunity. Once the innate immunity fails, or as continuation to the innate immunity, the adaptive immunity is activated to the various infectious agents. So the specific antigen is detected by the B and T lymphocytes, and they produces the various antibodies as well as the cytotoxic effect. And once the inflammation subsides, they turn out to be memory cells. We will go through the detail in this slide. In this slide, and here the T and B lymphocytes, they recognizes the antigen presenting cells which has, let's say for COVID, S and N antigens. So these have been recognized by the T and B lymphocytes. Then later they undergo the clonal expansion or clonal proliferation. The B lymphocytes further turns out to be activates to become plasma cells, and they produce antibody. Meanwhile, the T lymphocytes, activation of these T lymphocytes, they turn out to be effector lymphocytes, and they induce a cell-mediated immunity. So say ultimately both humoral or the antibody-mediated immunity and cell-mediated immunity further destroys the or induces apoptosis or induces cell death of the affected cells. And with that, we expect to have the inflammation or the infection to be under control. And once that is over, these lymphocytes turn out to be memory cells, and they remain, they are active for a longer period. And specific to this, yes. And as we can see here, the spike proteins, normally how this the antibodies affects, they are called as, once they are effective against this infection, we call them as neutralizing antibodies. In terms of COVID, two important neutralizing antibodies are detected. One is S and N. Now, normally we have seen that with the spike antigens are recognized by the ACE receptor. Meanwhile, in presence of spike antibodies, what happens is they prevent the interaction of this spike antigen with the ACE receptor by binding with the spike antigens. So this antibodies binds with this, and they neutralizes the action, as well as they prevent the further proliferation, further binding, and hence the proliferation of the virus. And S virus prevents virus binding with host cells. Meanwhile, N antigens or N antibody interfere with viral multiplication. So these two forms the key important factors for the vaccine efficacy. So for all vaccines, if you see, either they produces S antigens within the body and then resulting in the production of S antibodies, or N antibodies, or both together, depending upon the vaccine. And this is how the one of the main function how the vaccine activates. Now let's review this through the at the diagnostic window. With infection, initially it provokes the innate immunity, and then by around 7th or approximately 7th day, the adaptive responses also get activated. The B cells started to produce the IgM. It can be S IgM or it can be N IgM. Once the IgM forms the antibody S IgM as well as N and IgM, and after this, the IgG started to it just switches over to IgG. IgMs, by around 15th to 20th day, IgM production is completely stopped, and that is taken over by the IgG. And at this stage, if you measure, around 70 to 80% of the antibodies are of IgG type. So this is how the antibody responses. This can be of S IgM and S IgG, or it can be of N IgM and N IgG. And subsequently, once the infection subsides, this antibody level also subsides. May vary from 20 days to 30 days to 90 days. So the various, depending upon each individual, there can be variation. But at the same time, this has resulted in the production of memory cells, and these memory cells, anytime there is a second infection or a second stimulus, they can produce immediately IgGs against the virus. So this is called as the anamnestic response, or the specific antigenic response or antibody response to the second response by that same infection. So this is the anamnestic response. If you have not understood this properly, I can give one example of another species which has this anamnestic response is said to be the female. How specifically they remember the birthdays, wedding anniversaries, and so on. And normally there is a normal response to that associated with it. But imagine if one fine day you missed that, and you missed your wedding anniversary or or our birthday, what happens is there can be an hypersensitivity reaction. In the same way, at times when there is a second stimulus as an original infection, sometimes it can provoke hypersensitivity reactions. And this can result in marked cell death as well as another cytokine storm. And that is then the worst that can affect is the immunodeficiency, where in which there is no response to this the primary as well as the second stimulus. Now let's see, the same is effective in discussing, the same diagnostic window is effective in discussing the vaccine efficacy also. With the first dose of vaccine, what happens is it immediately provokes some kind of innate immunity, as well as it provokes the B and T cells. Both cells are activated, and that results in the production of IgM. If it is Pfizer, only S IgM is produced, and later it changes to S IgG. So this is the basis of the first response or the first dosage of vaccine. Now later, once this subsides, we provide with a second stimulus, and the second stimulus provokes another response from the memory cells immediately that raises the IgG levels immediately. So these two forms, this is one of the reasons why we give the booster dose, and that makes sure that the memory cells are active and the immunity lasts for a longer period. The same way, there are also risks where we have noticed that some people who had the second dose, they had hypersensitivity reaction with marked proaquilant activation as well as the cytokine storm, and at times very rare reports of some deaths also have mentioned as part of a hypersensitivity reaction. But it happens in those with at elderly age above 90 mostly, as well as those with multiple comorbidities. So the basic immunity, how act is defined, you can see in this window itself. Now let's go to the kind of vaccines available. The first, let's take the Pfizer vaccine. The Pfizer vaccine, there is mRNA that is capable of producing the spike antigens are coated in a lipid cell wall, a lipid wall. That is, normally our cell walls has lipid and protein, lipoprotein cell membrane, that's what we call it as. Meanwhile, this has only lipid or very primitive in nature. So very primitive in nature. That is why this need to be stored at -70 degrees. Once it is brought to the room temperature or once injected into the body, this lipid cell membrane fuses with our cells, and this mRNA translates the entire cell function and resulting in the production of spike antigens. These spike antigens, once released, the body recognizes them as foreign, and antibody, the same B cells and the same T cells acts against it and resulting in the production of the various antibodies. Now let's come back. In the Pfizer or Moderna, the mRNA activates host cell to make spike protein, and the host antigen presenting cells recognize them, resulting in the development of antibody. Similarly, in the Oxford AstraZeneca, that's usually called as the Covishield, in this also there is a vector, adenovirus vector, in that they have the codes for the genomic codes for the spike protein is incorporated, and once it is injected within the body, they both produces, ultimately they both produces spike antibody. That is why this vaccine efficacy, if you want to evaluate, we need to go for spike antibody. At the same time, the other two are the Sinopharm and the Bharat Biotech. In both, they use the whole virus inactivated. The inactivated whole virus is used. And not only it provokes spike antibodies, it also provokes N antibodies. That is, so the nuclear membrane antibodies also is provoked. So this can be detected by N antibodies also. Meanwhile, as all these variants, the various vaccines are effective or can be activity can be detected by spike antibody. That is why they recommend the usage of spike antibodies. This is in brief about the vaccine. Now let's discuss about the vaccine response. Vaccine response is not limited to the antibody alone. When we vaccinate, what happens is it activates both B and T lymphocytes, resulting in the adaptive, active artificial immunity, that is the adaptive immunity. And B cells produces antibody, which we can measure. Meanwhile, T lymphocytes produces cytotoxic effects, as well as both ends up in the formation of memory cells. We are not in a position to measure or recognize these variations, that is the T lymphocyte effects as well as the memory cells role. In addition to that, there is some role in the innate immunity also. Vaccination also activates the NK cells and the dendritic cells. And in addition, I think we have not mentioned about in this one, the third antibody type is the IgA. The IgA also is produced with infection as well as with vaccination. This IgA is coated over the mucous membrane, especially on the respiratory membrane as well as the GI mucous membrane. And the IgA persists for a longer period, and that also provides immunity, both in terms of the natural infection as well as in terms of the vaccine-induced artificial immunity. Let's come back. So now see, the IgA also is there. So of all these variants of immunity, we only measure B cell related antibody formation. But that also naturally it lasts for a short period. Then subsequently it is provoked by a second response, a second infection, or anytime the booster dose, as well as whenever we get exposed to the COVID virus further. So coming to the evaluation of the vaccine efficacy, the question is it required? Efficacy cannot be judged by antibody level alone. We can only measure IgG and IgM, and that lasts only for a limited period. IgA also is produced and is present in the mucosa of the respiratory tract for a longer period. T cell response as well as anamnestic memory both cannot be measured, and it is not practical to evaluate them on a case-to-case basis. But during the clinical trials, this has been evaluated, both neutralizing effect of the antibody as well as the efficacy of the T cells and the memory cells have been measured. In addition to that, the cytokine, the innate immunity also, we are not focusing on that. We will not be able to measure it on a regular basis. What has been noticed is that the cytokine storm found to be less in those vaccinated. This is very important. And we had numerous vaccinations in the past. Have we ever evaluated them? But we know they have provided us immunity, and due to which, the various holy trips we make to the Rome or for Hajj as well as Kumbh Mela, they made it mandatory to have these vaccinations, and they have helped in providing herd immunity. When around 50% of the community is affected, around 30% of the people will have immunity. Meanwhile, if you increase that to 70% vaccinated community, around 50% of the people will develop immunity against COVID. And once we have a society around 100%, that may not be practically feasible, almost 100%, that provides immunity. Around 70 to 80% of the people will have immunity, and that is sufficient. From our experience with the vaccines in the past, like oral polio vaccines, mumps, rubella, all these cases, almost 70 to 80% of the people have been vaccinated, and that provides herd immunity for a longer time. Meanwhile, the antibody measurement we need to be restricted to symptomatic cases with repeated negative PCR. This is where one of the indication wherein which antibody need to be measured. Then to evaluate those with immune deficiency, like those who are undergoing cancer therapy and or genetic immune deficiency, AIDS. In such cases, it is having a co-infection as COVID may not be a right time, so it is better to evaluate their immune deficiency. For that, we may require the antibody level. As well as we need this whenever we need to provoke or treat a COVID positive patient with passive passive immunity, that is by giving them immune sera, the patients who had previous infection and those who are having sufficient antibodies. To evaluate, to quantify that, we may require this test antibody measurement again. Dr. Dirar, you can come back. This is the reference of most of the reference, and the immunity. I've referred my old Logan's textbook of pathology, which we all are familiar with. And one advantage we had with this COVID is that we realized the importance of freedom. The freedom to live together, the freedom to avoid, to gather one another, the freedom to meet our family members, the freedom to fly, freedom to travel, all this. And so that's about my, thank you so much for patient listening. Dr. Dirar.
Oh, thank you very much, Doctor. Doctor, it was really indeed a very, very informative session. In fact, I've already requested all the doctors who are actually currently watching us, all the attendees, to go ahead and ask questions in the Q&A session. You can see a question mark box on the top right of your screen, just next to leave, and you can always ask a question there, and I will read out to Dr. Anthony, and he will answer your questions if you have any. Thank you. Doctor, can I ask you a question?
Yes, please.
Doctor, a lot of people have this, because we are doing a lot of webinars in and outside Prime, actually, and like mostly with corporates. A lot of people have questions which vaccine to take. Obviously there are pros and cons for all the vaccines. So in that case, what would be a general answer that I can get for my satisfaction in case if I'm a person, a layman who wants to ask a question on this part, which one to be referred for?
Simple answer is whatever is easily available, take that and ensure that the same is, as a booster dose also, you take that same vaccine. That's all, because all have its pros and cons. And for a young person, probably Pfizer is quite one of the, this Oxford, AstraZeneca, Pfizer, they all have proved to be highly effective. Meanwhile, Sinopharm and this inactivated virus, Sinopharm, there's Covaxin and so on, wherever there is inactivated vaccine, they seem to be more safe for the elderly population.
That's great. So there is no superiority, I should say, right?
Absolutely. As of now, we cannot claim any, we cannot take up any of this. Probably the Pfizer and Oxford, AstraZeneca, almost 90% immunity is assured in this. Meanwhile, with the Sinopharm and whenever you use the inactivated, it says around 80%, plus and minus variation. This is not going to make any major difference in your decision which vaccine to take. But the decision which we need to take is how it's better to have the vaccination as soon as possible. And elderly people better to avoid this. Elderly means above 85, 90 and all. It is better to avoid this because of the hypersensitivity.
Right. Absolutely. Thank you, doctor. Doctor, I've got a question here. The question says, after what period can one take the Pfizer vaccine after suffering from the infection?
The circular from the DHA says that 21 days if they have a mild infection or a asymptomatic PCR positive, 21 days after that PCR test. Meanwhile, recently, when we called the vaccine centers, they say about 90 days. The definite circular, we have not received anything in that matter. But 21 days after the mild and asymptomatic cases will be ideal, can be followed. I am not saying will be ideal, can be followed. And those who had severe infection, as well as those who got admitted in the hospital, they need to wait 90 days. That is the definite protocol which we know about.
Thank you, doctor. Another question, doctor. Any long-term complications for Pfizer vaccine?
See, it is as if like we cannot it long term in the sense there are a lot of if I use that word, nonsenses goes through the through the media, especially WhatsApp and so on. So many people, and they state so many kind of complications related with these vaccines. They are not proven, and then the spike protein which has been activated as well as the spike antibody, they don't interfere with any of our nucleus or genetic system. In addition to that, there are no components that are harmful to the general public. So there is no reason to expect a complication at a later onset for all these viruses. And in addition, these inactivated viruses which are there, see the only the new technology we can say in this is about this, the Pfizer one, where in which this mRNA is introduced into the cell. Meanwhile, these three, they have been there in place. This technology is there in place at least 50 to 70 years. The oral polio vaccines, the TB vaccines, then the various other vaccines which we take, they are all related to that. They don't have any complications. And even this technology by the Pfizer is also nothing new. It has been used in the oncology field for over 15 years. So we do not see anything.
Thank you. Doctor, how long can we be protected by the vaccination taken? Will a booster be required?
See, all vaccines, they recommend a booster dose. All COVID vaccines, they recommend a booster dose. Some vary from 21 days to 90 days. Some, especially AstraZeneca, they have stated that the booster dose should be taken at 90 days. Definitely, this will provide. Now, see, our body never got exposed to the coronavirus in the past, other than the Middle East respiratory syndrome, MERS, and so on. Other than that, we never got exposed to the coronavirus. So this is an exposure to the coronavirus, and later onset, once we get vaccinated or once we get the original infection, this will provide us immunity, and this disease in the long run will become like a common cold. Common cold, I mean the influenza, it will become something like that. Almost 100 years before, the same common cold, the influenza, turned out to be Spanish flu and killed millions of people. In those days, there was no vaccine. Today, we live in the modern world. Luckily, we have these vaccines, and it's good that the scientific forum is able to develop this vaccine in a span of 6 months to 1 year period from the time in which this got infected. So this was a challenge, definitely. That is because of the development of the science, wherein which we are able to develop this vaccine this immediately. Anything else? Fahad, you too started sleeping, Fahad?
No, doctor, sorry, I was on mute. Actually, I was asking a question. I didn't you. Sorry again. The question says, I'll repeat it again. Actually, I was on mute. We are getting queries from patients. What is the level of antibody where we can safely say patient doesn't require booster dose? I believe it's more of a question that was asked earlier.
Yes. See, the booster dose is mandatory, and it do not depend on your antibody level. Booster dose is mandatory, and it does not depend on your antibody level. And the recommendation now is that this is the multiple clinical trials these have gone through. The recommendation is that yes, this is going to provide us immunity, but how long we cannot predict. We need to wait for the next 3, 4 years to 5 years to see what exactly the how it is going to control the COVID infection in reality. That we need to wait and see. But it is effective in multiple ways.
All right. Doctor, if a person had a coronavirus infection in the past, not COVID-19, other coronavirus infection, can this person have immunity to COVID-19?
Other coronavirus is only the the Middle East respiratory syndrome, which happened somewhere around 4 or 5 years back in this region also, and that was to the COVID. Those who work with the camel, not in the community. So 99.999% of the rest of the population is not being exposed to coronavirus. So that question won't arise as a general public. But those who had MERS and yes, or SARS, the SARS also another coronavirus. But this has not even affected 0.1% of the community. They were not pandemics. They were just like they call that epidemic.
Thank you, doctor. Another question: for how long the vaccination will protect against COVID-19? What recommendations about how many times the person can take the vaccine per year?
We need to wait and see. And I don't think they will recommend this like that of a multivitamin to take every year, every month, and so on. Meanwhile, this can turn out to be something like our influenza vaccination, which is recommended for people who have immunodeficiency, who are who are working in the hospital and so on, wherein for such people also this influenza vaccine is given. So finally, ultimately, after a certain stage, once the general community develop, at least 50% of the people develop immunity, which we call it as herd immunity. Once that is done, the chance for them to take these shots further is least likely, except for those who are immunosuppressed and so on.
Great. Doctor, I believe a very common question nowadays people are asking, and I have this question here. After infected with COVID, how long we can take the first dose of vaccine? Like, what's the time that we need to wait to, take the first dose after we're positive?
Pardon? Can you please?
Yeah, I'll repeat it. After infected with COVID-19,
yes.
How long we can take the first dose of vaccine? Means a person has been infected. After recovery, what is the time frame after which the person should take the vaccine dose?
Yes, this we have already answered. Those who had asymptomatic or mild infection, they have to wait 21 days. That is the recommendation. Meanwhile, those who had severe infection, they have to wait 90 days. That is the recommendation. Meanwhile, now, the call centers, they ask everyone to wait for 90 days.
All right. So generally, if we will say it's 90 days that we can.
So in practice, that is happening. Definitely, there is no report saying that within that 90 days somebody else has had a second infection, until and unless it turns out to be a false PCR. There is no evidence to prove that in the 90 days time they had developed infection.
Great, thank you. Doctor, a question, pardon me for medical term if I'll pronounce it wrong. What if someone has developed low immunity following COVID and has developed esophageal candida? Can he take 2 doses of vaccine with weight loss also?
If they have developed, if they have developed esophageal candida, or that means they have a immunosuppression, and that is not related to the COVID, may be related to some other factor. It may be on cancer treatment, or they may have a genetic or congenital, hereditary immunodeficiency, or a acute infectious disease, AIDS or so. In such cases, the treatment is different. And in order to prevent COVID, they have been given, this kind of cases have been given passive immunity, that is by giving the immune sera, as well as by third dose of vaccination. This also been attempted. Even in cases, third dose of vaccination in some centers for those who have congenital or hereditary immunodeficiency. They have given that.
Understood. Doctor, can cancer patients take the vaccine?
Cancer patients can take the vaccine. There is no, especially that is in such a case, it is better to go for inactivated vaccines rather than a Pfizer vaccine. Meanwhile, those who have autoimmune diseases and allergic diseases, that is also a type of hypersensitivity reactions. Can you still see my screen?
Oh, yes, doctor. Yes, doctor.
Okay, that is also a type of hypersensitivity reaction. So this, those who have autoimmune diseases, that means not the mild kind of autoimmune disease, severe autoimmune disease, as well as with severe allergic diseases. So they need to be careful and sometimes, especially the elderly with hypersensitivity reactions of various kinds, have been.
Understood, doctor. Thank you. Doctor, we have seen women having more side effects than men. Is there any significant reason for that?
Related to the vaccination or infection?
Yeah, post-vaccination.
Post-vaccination.
Yeah, post-vaccination.
I wish Dr. Didar would have been here to answer that. I've not heard anything like that. Dr. Didar, can you join us?
Actually, we've trying to reach him, but he was not able to join in as a presenter because of some technical error on this part. We can take this question definitely later on. Dr. Asya has asked this question, and we can reply her definitely.
Okay.
Yes. Okay, doctor. Which vaccine is having the least side effect?
Who wants to put me into trouble? It's not now coming to, I have already mentioned this, answered these things. All these are safe, but for those elderly above 80 years and so on, better to avoid these two variants because of the chance for having a hypersensitivity reaction is higher. And the old Newton's law, to every action there is a opposite reaction. That is true with vaccination also. As long as you have an active vaccination, there can be a opposite reaction. That is the at times, it can turn out to be hypersensitivity reaction. So that is one of the reasons. Meanwhile, those who have allergic diseases, autoimmune disease, elderly, for them this inactivated vaccine will be more safe. And coming to the immune status evaluation, almost 90% of immunity has been offered by this two. Meanwhile, this is around 80%. That won't make any difference. Yes.
Understood, doctor. Doctor, coming to the probably, I guess, yeah, I've got one more question. What is the recommendation for mothers who are breastfeeding? Which vaccine is safe, and where is this available in the buy?
Okay, so there's a mothers breastfeeding and the children, they are under clinical trial. So all these vaccines, they are currently evaluating the children, And recently, the children less than previously it was about 18 years. That was the age group. Now children of 16 years also can take all these vaccines. That is the recent recommendation. Regarding the mothers, breastfeeding mothers, that even here in UAE they started evaluating that, and to some of them they have given this, and it has not affected, not noticed any issue, but still we are waiting for any official
thank you
guideline. But I'm sure for see something related with the IgM and IgG is that IgM cannot be transferred to placenta. Meanwhile, IgG can be transferred to the placenta. And recently there was a study that the child born out of a mother who had COVID infection, IgG was noticed. That means that is protective in nature. Meanwhile, a newborn baby has IgM, COVID IgM. That means the baby is having the current infection. So that is about IgM and IgG we need to keep in mind.
Right, Doctor, moving towards another question that I have, I believe this is, no, we've got another one also. So Doctor, what is the recommendation for, Doctor, post-COVID infection, what's better to check, PCR test or antibody test?
Post-COVID, if you have completed your quarantine period after general symptoms and so on, except those who had mild infection, after 10 days you need not go for PCR test nor antibody testing. Meanwhile, severe symptoms, those who are admitted in the hospital and so on, before releasing them, they need to do the COVID PCR. Only that is COVID PCR is in a follow-up is required only for those with the severe symptoms admitted in the hospital and so on. Those who are on home quarantine and so on, they do not require any follow-up test.
Got it, Doctor. Thank you so very much, Doctor. I think these are the questions that we have got, Doctor, and I believe we have appreciation also coming in from the doctors itself. We do not have any more further questions. So shall we proceed towards the ending of the session, Doctor?
Thank you, Fahad, for arranging this. Thank you, Dr. Dirar. Dr. would have been here. Dr. Dirar would have been here, then it would have enriched more.
Absolutely. Thank you everyone for joining us today. Apologies once again for a technical glitch in the beginning, and I believe it was really a very informative session by Doctor. To all the doctors, of course, and very important questions are being answered at this time. I would really say if you have any questions, still you can always send an email to Dr. Anthony if you don't mind. I'm mentioning that. And you'll get your answers from Dr. Antony. And thank you so very much, Dr. Dirar. Unfortunately, because of some technical glitch, he was not able to continue with the session, but I'm sure he's listening to us as an attendee. So thank you so very much, Dr. Antony and Dr. Dirar, for arranging this session. Of course, with Prime Digital. So thank you once again. Take care, everyone.
Fahad?
Yes, Doctor, please.
We have a very strong team. I have to thank the entire team and the COVID task force, Dr. Adil, and the various members of the task force, the nursing team. So let's thank all of them and thank you so much, Fahad.
Absolutely. Thank you so very much, Doctor. You're absolutely right. Prime has definitely a very strong team where we are really, thankful the information, the guidance, the actions that are taken. It's really great. We are really thankful to whole of the management, I should say, of course, of this. Thank you very much once again, Doctor. Thank you to everyone for joining us. Take care. Bye-bye.